So we're going to move from the spine to the brain, and I'm going to talk a little bit more on some different aspects of trauma imaging and subtitle this, so you think you know everything about head trauma imaging, maybe we ought to think again. So one of my favorite movies is called The Usual Suspects, and this particular Kevin Spacey movie, which is one of my favorites, says, in a world where nothing is what it seems, you've got to look beyond the usual suspects. And so what we're going to do today in our trauma imaging is to talk about looking beyond the usual suspects from what you usually think of for trauma. We're going to start with talking about the scalp, an often neglected area of imaging. It's not just a covering. We're going to learn that not all epidural hematomas are the same. We're going to look at some variations on the themes of subdural hematomas, including some concepts about excitotoxic brain injury and abusive head trauma that may be new to you. We'll talk a little bit about chronic traumatic encephalopathy, and then close with diffuse vascular imaging, diffuse vascular injury, which may be a new kind of high-velocity impact injury. So let's start with the outside and move in. And let's start with the scalp. We don't need to remember all 5 layers of the scalp. As a matter of fact, can we have a plain piece of paper that doesn't have a shiny surface so that the arrow doesn't bounce around here? There are 5 layers of the scalp. Really only 2 of them are important. And we're going to be talking primarily about the Galea aponeurotica. Thanks. This one, I think it'll show a little better. Good. Galea aponeurotica and the subaponeurotic tissue and the periosteum of the skull, which is the pericranium. So we're going to be looking primarily at the Galea, which we see here depicted as this kind of grayish band, and the pericranium, which is the periosteum of the skull right here. So with that little bit of anatomy introduction, why does all of this matter? Well, not all scalp hematomas are the same. If you think that your residents know everything about trauma, ask them what is the difference between a cephalohematoma and a subgaleal hematoma, and I guarantee you they're going to probably a little bit and stick their fingers up their nose and kind of, weasel around and lay words on it, because they probably don't really understand the difference. Well, now we will. A cephalohematoma is basically a subperiosteal hematoma. It's the extracranial equivalent, if you wish, of an epidural hematoma. It's going to be limited by the sutures in the fontanelles, and it's relatively small and typically covers a single bone. So here on our anatomic diagram, this smaller hematoma is a cephalohematoma. Think of it as a subperiosteal or extracranial, quote, epidural hematoma. Contrast that with a subgaleal hematoma. It's not bounded by sutures, and it can become literally huge. It can extend all the way around the skull, as it does here, and the blood loss, particularly in infants and small children, can literally become life-threatening. So let's first look at our cephalohematoma. These are going to be limited by size. Remember, they're limited by, bounded by sutures. They're typically going to cover a single bone. And as we see in this particular case here is a typical cephalohematoma from a traumatic forceps delivery. That's a common way they happen. Here you can see a skull fracture underneath. And this is a typical cephalohematoma. Because these are self-limited, they're typically, and they're common in instrumented delivery, these things are rarely imaged, and they're certainly usually not followed up. They're self-limited. They resolve spontaneously. They don't need follow-up. And chronic, occasionally you can calcify, but basically we really don't see many of these. So 99 times out of 100, unless you're dealing with a newborn ICU, the patients that we see with scalp hematomas are going to be subgaleal hematomas. Even large cephalohematomas, and here look at this example of an abused infant. Obviously stuff is going on intracranially. We're not going to talk about that right now, but look at this hematoma. It's an enormous cephalohematoma, but it's only covering one bone, and it doesn't cross the midline. Now, look in the coronal reformat scans, and you might say, but you just told me it doesn't cross the midline, but here it does. Well, look very carefully. Here is the elevated periosteum, and there are actually at least 2 and possibly even 3 cephalohematomas in this infant, each one of which is bounded by the periosteum. So here, sagittal reconstruction, you can actually see a really nice example of a cephalohematoma. Now, I'm going to go back and show you why that happens. Anatomically now, let's take our periosteum, and you'll see that the periosteum of the skull is continuous through the suture with the outer layer or the periosteal layer of the dura. That's why it doesn't cross the midline and doesn't cross sites of sutural attachment. Even large cephalohematomas, then, if we look carefully, we should be able to find the shadow of the elevated periosteum. Now, subgaleal hematomas are a different story. Remember, cephalohematomas, usually self-limited, single bone, typically don't cross lines of sutural attachment. Subgaleal hematomas do. They are basically a subaponeurotic hematoma, and they will cross under the aponeurosis and the occipitofrontalis muscle. They are external to the periosteum, so there is nothing that limits a subgaleal hematoma from accumulating and getting bigger and bigger and bigger. And here's an autopsy case of an abused infant with a subgaleal hematoma. In this case, you can see it crossing the midline. It's really very extensive, often bilateral. Crosses sutures, crosses fontanelles, may spread entirely around the skull, so it looks like the child is really surrounded by a balloon or an inner tube, if you will. These can become absolutely enormous. Here are 2 examples. They're both extensive. Here's an infant. You see it crossing the midline. This is a subgaleal hematoma. Here's another one in an adult crossing the midline. In the infant, a subgaleal hematoma can become life-threatening. In an adult with a coagulopathy, it's surprising how much blood you can lose. And just as we look for swirl signs in epi and subdural hematomas, in older adults, if they show this kind of heterogeneity in the density of the subgaleal hematoma, but where there may be active bleeding going on. And these can get absolutely enormous. Okay, so now we're going to move from the outside to the inside of the skull, and we're going to talk about epidural hematomas. Yeah. You've all heard about epidural hematomas. There's no mystery here. Typically, a classic epidural hematoma lacerates a blood vessel, usually an artery, and most commonly the middle meningeal artery. And if you're getting active bleeding, we get the so-called swirl sign. So where does an epidural hematoma accumulate? It accumulates between the inner table of the skull and the outer or the periosteal layer of the dura. Very typical. Let's look at an autopsy case of an epidural hematoma. On the right, we have the picture of the dura intact with the epidural hematoma as this biconvex blood collection. And here is the skull seen from the inside, and you actually can see the outline of the epidural hematoma. Here to the left is a fresh autopsy case. The brain has been removed. This is a patient who died of complications from the trauma. And we can see the comminuted, partly depressed fracture. We can see the epidural hematoma here as this acute current jelly clots. Note that epidural hematomas may cross sites of dural attachment, particularly if they are venous. They rarely cross sutures, but that is not a hard and fast rule, particularly when you're dealing with children. About 10% of pediatric epidural hematomas actually do cross lines of sutural attachment. Most of these are unilateral and supratentorial and have this biconvex shape. You've all seen this, bloody. So we're not going to spend a whole lot of time on your typical epidural hematoma. So one of the messages of this afternoon is epidural hematomas, we all know them, but they are not all the same. We've talked about the classic epidural hematoma, which is an arterial laceration. But there are venous epidurals. There are what are called vertex epidurals, the ones that occur right over the top of the brain. There are anterior medial fossa epidurals and clival epidurals. Some of these are surgical emergencies. Some of them are beware, watch me carefully, and others of them are, it's there, we describe it, but it is not going to matter in the patient's treatment because they're never going to get any bigger. So, let's look now at venous epidural hematomas. Yes, arterial are much more common than venous, but now that we have the ability to do our fast, thin section CTs with multiplanar reformatted images, I think this is going to change because we're seeing more venous epidural hematomas, particularly in patients who have high impact injuries and complex comminuted fractures at the skull base. Remember that fractures can be linear or diastatic, and if they cross a dural venous sinus, particularly at the skull base or the vertex, they can produce a venous epidural hematoma. And here on our anatomic diagram, we have drawn some kind of complicated, complex, dramatic skull-base fractures. And we'll see that if this one crosses the site of dural attachment and a venous channel, here's a skull base fracture through the squamous part of the occipital bone, it can tear the venous sinus and produce a venous epidural. Here is an autopsy case underneath. Here's the dura partly lifted up. Here is an epidural hematoma. This is the site of attachment to the temporal bone, and you see the dura here, and here's the epidural hematoma crossing the site of dural attachment. This is a venous epidural hematoma, and it can also commonly cross sutures. So if you remember people saying, no, epidural hematomas don't cross, beware, indeed they do. Venous epidurals are easily overlooked. Our reformatted scans are absolutely key to the diagnosis, and CTA or CTV are very helpful. Here's an example. Here's a patient with a scalp injury. The scalp is our friend. It tells us that this is probably the site of the blow. We see a contralateral and the contralateral temporal lobe hematoma here, and then we see what appears to be is it subdural, is it epidural? Well, I don't really know. Here is the skull view, and you can see there's a diastatic fracture through the lambdoid suture. And here on the coronal and sagittal reformatted CTVs, we see this venous epidural lifting up the dura and crossing the site of sutural attachment. Classic venous epidural hematoma involving both the supra and the infratentorial compartments. Vertex epidural hematomas are rare. They typically occur when there's a linear or a diastatic fracture that crosses the superior sagittal sinus and the midline. They are usually venous, and their size is grossly underestimated on axial CT scans, even relatively thin section ones. It's going to be our coronal and sagittal reformatted scans that are most helpful in these cases. These are also difficult to diagnose clinically. The patient may have few or very slowly developing symptoms because, unlike an epidural hematoma of arterial origin, this guy is accumulating relatively slowly. So here's a classic vertex epidural hematoma. How much do you see on our axial non-contrast soft tissue windows? Not very much. We see a big subgaleal hematoma, see a little bit of air. Here are fracture lines that we can see crossing the midline, but look, it's the sagittal reformatted scans, and this patient has not one, but two venous epidurals, and here you see it displacing the superior sagittal sinus inferiorly. These are venous epidural hematomas. These are watch me carefully over the next 24, 48, or 72 hours because they can slowly accumulate blood and slowly cause increasing mass effect on the underlying brain. These guys are dangerous. They don't require immediate evacuation usually, but they do require close interval follow-up and observation. It's amazing how little you can see sometimes on our axial scans. Here's a patient, big, huge subgaleal hematoma, depressed comminuted fracture here, here it is across the bone. We said this patient is in danger of having a venous epidural hematoma, and we ought to do a CTA or CTV, and the neurosurgery resident on call said, no, we don't need to do that, patient's doing just fine. But several hours later began to deteriorate, and for whatever reason, they ordered an MR scan, and this one clearly shows our classic venous epidural. So when that fracture crosses over the top of the head and engages the superior sagittal sinus, beware. It's always a good idea. You can't go wrong getting a CTA/CTV. And I always say, order a CTA. Don't order a CTV. If you order a CTV, the text may miss the bolus. If you order a CTA, you always get the V part for free, and there's not going to be a problem with that. So CTA is our friend. Okay, here's another type of epidural hematoma. It was described by Alyssa Jean from UCSF, who's one of our very best of trauma radiologists. It's called the anterior middle fossa epidural hematoma. It's about 10% of epidural hematomas. The deal about this one is it's anatomically limited. Here we see a classic anterior middle fossa epidural hematoma right there. It's usually small. It's limited by the sphenoparietal suture laterally and by the orbital fissure medially. So it's never going to get any bigger. All of these patients have fractures. If you do bone windows, you can easily see fractures typically going across the sphenoid wing or the zygomatical maxillary suture. These guys are venous. They're not arterial. They are no clinical importance. They don't get bigger. And no reported cases in the literature, the last that I looked, ever required surgery. And the reason that these things occur is anatomically explained by this diagram. Here it is the sphenoparietal sinus that is curving along the greater wing of the sphenoid. It's the sphenoparietal sinus that gets torn, but because the fracture, because the hematoma is limited medially by the orbital fissure and laterally, it won't get any bigger. For whatever reason, the surgeons in this case got spooked and they ordered a CTA, which we did, and we actually saw a little spot sign. They got all nervous and we said, don't worry, it's not going to get any bigger. This is anatomically limited. We followed it up 24 hours later, and indeed, it hadn't. Yes, it had a spot sign, but in this case, it's so anatomically limited, it's not going to get any bigger. And finally, clival epidural hematomas in patients with complex skull-base fractures. You may be able to see them like this, but they too are anatomically limited because the dura of the clivus is tightly attached to it, and it's never going to get much bigger than it is at the moment that you scan it. Now, what's new with subdural hematomas? We've learned that not all acute epidural hematomas are the same. We want to beware the venous epidurals, particularly the ones that have a fracture crossing the midline at the vertex. We know that the anterior middle fossa epidural hematomas and the clival epidurals we can describe, but they don't really mean anything in terms of requiring surgical intervention. Well, what's happened with acute subdural hematomas? There's kind of a lot going on with subdural hematomas. You know what they look like. They're going to spread diffusely over the surface of the brain. Here's an autopsy case that shows you what we were trying to depict on our anatomic diagram. It's a typical acute subdural hematoma. You've seen this, right? You've seen this. No problem. You've seen that. Is there anything new that we need to learn about subdural hematomas? Well, first of all, thank goodness we now have our multiplanar reformatted scans. We're not going to miss the small, thin subdural hematomas over the convexity. We're not going to miss these small, thin peritentorial hematomas, which may be difficult to see on the axial plane. Yeah, maybe there. Yes, I think it is, but no problem on the coronals and the sagittals. Note that on the sagittal reformatted scan, your normal tentorium, the dura of the tentorium, is going to appear slightly denser than the adjacent brain because it's slightly denser, but it's going to be thin. It's a thin white line. Anything more than a thin white line, it's a peritentorial subdural hematoma. So what else is new besides the use of reformatted scans? Well, it's what's going on with the brain under the subdural hematoma. You know about the phenomena of traumatic cerebral edema, but we're increasingly understanding that the brain under subdural hematomas is undergoing, in many cases, a form of excitotoxic brain injury in which they are going to get intracellular swelling, and that swelling may be absolutely catastrophic. So here's an autopsy case. This is one from my colleague Richard Hewlett, a neuropathologist in South Africa. You can see this patient obviously died. He had a small, thin subdural hematoma. This is a little traumatic subarachnoid hemorrhage, but look at the swollen gyri. What did this patient in was not the size of the subdural hematoma, it was the out of proportionate brain swelling that occurred. Is this because these patients actually have had a prior brain injury, and this is a form of second impact syndrome, which we'll talk about in a moment? Nobody really knows. But let me alert you to an imaging finding. So let's just look at our usual cases of cerebral edema, and then we'll look at what happens under small, thin subdural hematomas. Okay, let us look at this CT scan. This is an older patient who fell, was not anticoagulated, was not really doing very well. And you can look at his scan. Here is the non-con CT on the left. Let me grab the arrow here. There's a little thin subdural hematoma there. You can see it a little bit better on our kind of intermediate windows. Yes, it's extending along the interhemispheric fissure, but this patient isn't doing well. Why is this patient not doing well? Well, look at the brain underlying this is like a 2 to 3 millimeter subdural hematoma. Not anything the neurosurgeons are ever going to worry about. However, look at the brain on the opposite side. How thick is the cortex? Just a few millimeters thick. There's the gray matter, white matter interface. You see the sulci over the surface. Look at how thick this cortex is. This patient is having a really bad excitotoxic brain swelling, and this is life-threatening. It is not the 2 to 3 millimeter subdural that's life-threatening. It's the brain swelling that's going on underneath it. Occasionally, we will get MR scans. Here's a patient who was not doing well a couple of days, 3 days after his injury. And here is a subdural hematoma. That's not what I call your attention to. It's the brain swelling, and it's the cortex. It's in a non-vascular distribution. This is not vascular injury to the middle cerebral artery because it's crossing vascular territories, and it's really not involving the white matter. This is excitotoxic brain injury. Is this second impact syndrome? This is something that Alyssa Jean has described. This is when you get an athlete, typically a teenage or early 20-ish male who's involved in contact sports, gets a concussion, gets his bell rung, goes back to playing athletics before the brain has recovered, and then gets a second impact that now causes catastrophic brain swelling. It has been given the name second impact syndrome. So, we know about that in young athletes, most of us do, but does second impact syndrome occur in other clinical situations? And I think it does. I think it not only occurs in athletes, but it occurs in cases where there is non-sports related repetitive head injuries, two ends of the age scale. Infants with abusive head trauma, and older patients with repeated falls. And what I think happens is that the first trauma or the first concussion opens this temporal window of vulnerability, during which time, if there is a second injury, either abusive head trauma with inflicted injury or another fall, then they get disproportionate brain swelling. And here's a very sad case of a child with mixed subdural hematomas, and you can see the massive brain swelling that's way out of proportion to the size of the subdural. Let's look at the opposite end of the age spectrum. Here's an elderly patient with repeated falls. This is a recent case of ours. First fall has a normal CT scan. Second fall, 8 days later, a second normal CT scan. Third fall, 1 week later, he's got about an 8 millimeter subdural hematoma, but look at the mass effect, way disproportionate. This patient was herniating, and this patient was dying. They did a decompressive hemicraniectomy, and note that the edema is persisting even after they removed the subdural. The subdural was not the problem, it was the brain injury underneath, and that is probably a form of excitotoxic injury. So what is the take-home lesson? Look at the size of the subdural. Look at the size of the mass effect. If the mass effect is disproportionate to the amount or the thickness of the subdural, suspect excitotoxic brain injury. Alert your neurosurgeons, because they may want to do almost a prophylactic craniectomy to allow the brain swelling to occur. So it's the disproportionate size of the mass effect and the cortical swelling relative to the thin subdural. Here's another example. This is repetitive abusive head trauma. Initial CT scan, again, mass effect, yeah, it's a pretty decent sized subdural hematoma, but way more mass than you would expect. Look at the thickness of the cortex compared to the other side. He was not doing well after surgery. They'd evacuated the hematoma, and you see this diffuse non-vascular territory swelling of the cortex. And again, disproportionate brain swelling to the size of the hematoma, probably representing excitotoxic brain injury. Okay, what else is new about subdural compartment collections? Let's call them compartment collections. 3 types we need to deal with: subdural hemorrhage, in which blood is in that compartment; subdural hygromas, in which CSF is in that compartment; and a so-called hematohygroma, where there is mixed blood and CSF in the subdural compartment. So here's a susceptibility weighted scan in this infant with a hematohygroma, and note that in many of the cases where the blood is in the subdural compartment, you have little or no susceptibility effect. You'll look like it's mostly CSF and maybe a small amount of blood. This is a hematohygroma. What is the importance of a hematohygroma? What about mixed density subdural hematomas? What does it mean? Well, it can be a mix of hyperacute and acute blood. It could be all acute hemorrhage, but with some unclotted acute blood. It can be a hematohygroma, or it can be acute plus chronic blood. So in this case of abusive head trauma, it could be any one of those, which is an interesting conundrum for the radiologist. So let's look at what the difference is. A subdural hygroma occurs with trauma. It is a torn arachnoid through which CSF leaks into the subdural space. And so it typically has CSF character on both non-contrast CT and MR. And if you look at the fluid in this subdural hygroma, it contains beta trace protein, which is the marker for CSF. How does a subdural hygroma form? Well, there are lots of different theories. They all relate to head trauma, either surgical or closed head injury, and typically relate to an arachnoid tear or an intact arachnoid in which there is some type of meningeal injury, and you get the subdural hygroma. Note that in some cases, it can progress to a chronic subdural hematoma, because it will form a hematohygroma. So what do we look for as radiologists when we are looking for the potential for abusive head trauma? Here is a subdural hygroma 12 hours after a so-called normal CT scan. I think if you look carefully, you see that maybe there is a little bit of hemorrhage here, but most of this is a subdural hygroma. It's not a chronic subdural hematoma. Here is the MR. Here's the T2. And here's a flare. This is CSF. What does that mean? This means that this infant has been injured. So the key point here, and this is an AJNR article that appeared just a year ago, and I recommend it to you, the presence of a subdural hygroma, CSF, positive beta trace protein, in the infant and young child strongly suggests a post-traumatic state. It doesn't happen by itself, in other words, and should prompt the physician to search for other signs of injury. So we now know that finding a subdural hygroma in an infant or young child is an alert sign to look for other signs of trauma. Here's a hematohygroma. You can clearly see both the CSF and the fluid level. That is not so difficult to diagnose. Chronic subdural hemorrhage. Here's a case of chronic subdural hemorrhage. Doesn't look just like CSF, which is what a hygroma does. And finally, subdural membranes and how useful they are in looking in evaluating potentially abused infants. If you can give contrast and see a membrane form, then you know that that has been there a while. It takes a while to form a subdural membrane. So the key points when we're evaluating infants with subdural fluid collections, be descriptive. Our pediatric radiologists say avoid initial strong dating language. Serial brain imaging, NECT and MR helps in estimation, and certainly contrast enhanced MR adds useful information. T2 star is helpful in detecting hemorrhage, but remember, you don't always see it, so it doesn't rule out the presence of hemorrhage itself. Now, a couple of words before we finish on a very hot topic worldwide, which is chronic traumatic encephalopathy. You've heard about it with American football players. It occurs with hockey. It occurs with footy. And it occurs with young teenage girls playing soccer. So it occurs in many more than just football players. And here's what the NFL, National Football League in the US is saying: don't wait for the autopsy before you start thinking about protecting your brain. This is a very well-known NFL football player. It's really hard to talk about. Here's his suicide note. Please see that my brain is given to the NFL's brain bank. And then to preserve his brain, when he committed suicide, he shot himself through the heart instead of the head. And indeed, when they did the autopsy, they found changes, advanced changes of chronic traumatic encephalopathy. It is a worldwide concern. Traumatic brain injuries written up all over the CDC in Atlanta and the WHO in Switzerland. And here's what it does. Here's a normal brain on the left, a brain with mild traumatic encephalopathy in the middle, and with advanced traumatic encephalopathy on the right. These guys will have neurofibrillary tangles and so on, the changes that you will find identical to Alzheimer's disease. And in fact, chronic traumatic encephalopathy is now considered a tauopathy in the same family as Alzheimer's dementia. And again, here brown is the positive staining, and this is from mild all the way down to severe. And this is what happens in the temporal lobes and in the frontal lobes. These athletes that are subjected to repeated head injuries will begin to accumulate tau proteins and act like they have early onset Alzheimer's disease. Here is the one case that we've had at our institution, and this is a middle-aged patient who was clearly demented, had been a former NFL player. You can see the atrophy and the white matter changes in our susceptibility scan. This guy has multiple microbleeds all over the place. Chronic traumatic encephalopathy. People come up to me afterwards and say, well, you just told us about this, and you also told you what I'm going to tell you now, which is that teenage girls that play soccer head the ball an average of 400 times in a single season. Their neck muscles are not as strong as footy players, and so their heads undergo a lot of changes in angular momentum and acceleration, deceleration. It's now shown that these young girls who have no overt signs of cognitive disorders will show very early but subtle but definite changes of altered mental function. So if you come up and afterwards ask me and say, you know, my children or my granddaughters are playing this or that, what should I do? And I will tell you, you know, swimming and golf are very nice sports. So it doesn't take big head blows. Repeated subconcussive injuries do serious damage to the brain. There's been lots of stuff done on this, and I will just leave you with this thought that it is considered to be the cumulative impact burden over many, many times, not just the big head blows when you get your bell rung and actually lose consciousness. There can be no visible neurologic dysfunction, and yet these young teenage girls are already undergoing them. A last word about a interesting topic, which is called diffuse vascular injury. This is something the neuropathologists have described. It's not yet made its appearance in our literature, but I think it's real. When you have the very high speed motor vehicle accidents that we get on some of our motorways and very high dynamic impacts with very sudden, complex, rapid brain deformations, what you can get is tearing of brain blood vessels. We look for bright spots, the blood on our CT scans, and we call that sometimes axonal injury. But axons don't bleed. It's the blood vessels that do. And when we get these really bad, high-impact injuries, we will get compressions and tensions and shearings of brain blood vessels, and they are almost always fatal. Here are 2 autopsy cases, and you see these linear types of hemorrhage in the subcortical and deep white matter. This is what we look for. When there is discrepancy between what the CT scan looks like, here's a patient whose CT scan looks virtually normal. You don't really see much of anything. Maybe you can say there's a little brain swelling. I don't see the sulci and the cisterns too very well, but you don't see anything else. Glasgow Coma score, 5. So when there is a disconnect between what the patient's clinical score is and what the scan looks like, you can say, we're simply not seeing what's underlying. In this particular patient, same patient, here's our T2 weighted scan. You see multiple foci of restricted diffusion. More accurately than that, this is what this patient's susceptibility weighted scan, innumerable linear and petechial hemorrhages all over the brain. And this is diffuse vascular injury. So next time you're dealing with a trauma patient and it doesn't seem to be quite right, they're not doing well and their CT scan doesn't look particularly abnormal, if you can, do an MR with a T2 star scan. So in summary, there's more to head trauma than we might suppose. We need to learn to look beyond the usual suspects. Don't forget the scalp. Remember, what we're looking at is predominantly subgaleal hematomas, which can be life-threatening in infants and young children. Remember, not all epidural hematomas are the same. Some that you worry about, the regular ones, the venous ones, and the vertex ones, the anterior middle fossa, the clival epidurals, are typically self-limited. And remember the new entities: second impact syndrome, excitotoxic brain injury. And if you see more mass effect and cortical swelling than you can account for under the subdural hematoma, which can be very thin, alert the neurosurgeons that this patient may be developing catastrophic brain swelling early on. And finally, don't forget CTE, chronic traumatic encephalopathy, and this new entity of diffuse vascular injury, which is best depicted on susceptibility weighted scans. Thank you very much.